Hi, how are you? It's so nice to meet you. Good to see your face. My name is Lawana Brown, so we both have something in common
Yes.
with the last names. Is it okay if I call you Theresa?
Oh yeah,
That okay?
please
Okay,
do. Yeah.
great. So I'm a program manager with Regis College, which you probably already know, with the Women's Health Nurse Practitioner online track. So Regis puts out 600 plus nurses a year. So we have started this series of interviews where we like to talk about different issues surrounding nursing. And Andrew Levinsky, who reached out to you, has been finding so many wonderful folks for us to talk to. And so when he came to me and said, this nurse that wrote the book, and I was like, what book? And so I'm a reader, Theresa.
Yeah.
I read stuff. And I'm like, wait a minute, I had read this book. So he sent me the book. And so my first email back to him was, okay, can I keep this? This is my copy. I don't have to
Aw.
send it back, right? And he was like, no, you can keep it because I'm telling you, from a nurse that I worked in labor and delivery for years, probably about 10 years on night shift. And reading the book was like, I literally started reading it in the office while my husband was having an exam done for something else. And it was like, I didn't want to stop because I was committed to these patients and to
Oh.
your, everything that was going on, and I'm thinking, well, what's going to happen to this person? What's going to happen to that? And how is she feeling? And as you took on these assignments, it was just, so what I first want to begin with is, first of all, before we jump into the book, even though, as you can see, I'm really enamored by it, where did the nursing pathway start for you? I know in the book you mentioned that having your twins was kind of like a catalyst. So tell me a little bit about that whole process.
Yeah, so I have a PhD in English. I taught English for 3 years at Tufts University. Had my son in the middle of that, had this like, is this really what I want to do the rest of my life? And was staying home with him and got pregnant with twins. And then anyone who's had twins knows this, but it's really a life-changing experience.
I can't imagine. Oh my
Yeah.
goodness.
And we were planning on one more kid. Of course, we're very happy that now we have,
Yes.
yeah.
Mhm.
But I had midwives for that pregnancy. And when the girls were about 18 months old, we had a friend visit whose name was also Theresa, who was a nurse. And she and I were just talking. I said, I thought the midwives I had the coolest job in the world. And she said, Theresa, you could do that job. And it had never crossed my mind ever. Because no one in my family was in healthcare. I didn't even know any nurses. My husband's also an academic. We had this very, this life of professors and I just didn't know anything about it. But I started to look into it and found out, there's accelerated nursing programs for people who, if you already have a bachelor's degree or a PhD in something else, you can get your prerequisites and then fairly quickly get a nursing degree. And I was sold literally a month after that conversation. I was taking chemistry.
Oh, wow.
Yeah.
That's
So,
amazing. And
yeah.
I love that story so much because it goes back to the heart of labor and delivery too, and the experiences that surround that and how much of an effect they can have on the women that we take care of. So that is amazing that you were able to do that. So when did you finish your program? And then how did your first nursing floor experience, where was that? Was it straight to the unit, or tell me a little bit about that part?
Yeah, so I finished, God, I'm so bad at remembering years, and over 10 years ago. So we were in New Jersey when I was doing my prereqs, and then my husband got a job at University of Pittsburgh. We moved, so I got my nursing degree at Pitt's accelerated program, which is one crazy year.
1 year.
Yes.
Okay.
1 year.
Woo.
Well, yeah, I think it's a little bit too crammed in, and I did some of the classes. I took a year to get settled and get the kids settled, and did some of the classes then, which some of my classmates hated me for.
I know, because they were having to do it in real time. Oh my
Yeah,
goodness.
I don't know how they did it. it's intense, but if anybody only wants to spend a year, you could go to Pitt. You will have absolutely no life and you will hate the world, but you will be done in a year.
That should be a tagline for nursing school. You will have absolutely no life and you will hate the world. But in the end, you get the credentials because
right. And you'll be glad you did, you know, and that pain will, it's like labor and delivery, right? The pain, you forget the pain.
You do. That's why I have 4 kids, because I forgot.
Right.
I did forget. You're exactly right. But that is amazing. So first hospital, first floor experience, what was that like?
So I started at a hospital here doing oncology, intense oncology with leukemia and lymphoma patients.
Wow.
And there was a lot of bullying on that floor. So I pushed and insisted and wouldn't take no for an answer and moved to our sort of sister unit where they did bone marrow transplant. So a lot of the same doctors, same patients, separated by an elevator bay, but a completely different environment. Stayed there for about 5 years, then did outpatient oncology, but also infusions in a hospital, and then did home hospice. So
okay. Yeah. So that's a lot, a varied career. But, you know, so somewhere in that, where did the author, where did the English professor and the nurse meet and decide we're going to write a book about this? Tell me not only about that process for you. I don't write books, but I've written poetry my whole life. And so I know there's a process to the writing that is as much an experience for the person that's writing it as the people that read it. So talk to me a little bit about that process for you when the book was born, and also what you thought readers might take away from it, whether they be doctors, nurses, patients, that when they put this book down, what you thought they might be left with.
Yeah, well, that's an interesting question. I think my first book, Critical Care, which is roughly my first year of being a nurse, I wasn't even really thinking about the audience. It was much more just like I had all this stuff spinning around in my head, and it felt like such a relief just to get it down. And I think part of me was hoping it would be helpful to nursing students, which I've heard it is helpful. I mean, some of the nurses I've worked with said, you know, basically this idea that I'm too honest in the book and I'm going to scare people away. And I say, no, what I hear from people is they feel prepared after reading the book. But my second book, The Shift, which is 1 day in the hospital, I did have a very clear intention that I felt like I want people to see. I think of it as the texture of healthcare, and sort of how, you know, we get this idea from TV shows that modern healthcare is you have a doctor, right, who knows and does everything.
And all the nurses want the doctor, you know, so all built more about, and
the nurses occasionally empty a bedpan, or they say, can I help you, doctor? And as you know, the reality of modern healthcare is first about the nurse and the doctor are like this, like working together. But then there's all these other people, you know, there's transport, there's physical therapy, there's respiratory
nutrition,
therapy.
Everybody.
Right. And just, you know, and people can argue about how we should make it so that nurses can do more of that stuff they used to do. But the reality is where we are is it's a huge team of people who often never talk to each other, don't know each other. And I really wanted people to see that, because of course my ultimate goal is for healthcare to be more compassionate towards staff and patients.
Right.
I feel like people will only understand how much we need to improve our healthcare system if they understand what it's really like.
I understand that. And now that you say that, so much of what is in the book feeds into that. It makes me kind of think about, you know, years ago with Stephen Covey, I did the Covey Leadership Series, and he talks about the goose and the golden egg. And, you know, it makes me think about that in the hospital and workplaces, because we have this golden egg, this goal that we're trying to reach, but nobody thinks about the goose, you know. And so here's the goose, and whether that's somebody in, you know, healthcare, a nurse or whoever, you know, if you don't take care of the goose, you're not going to have the egg, at some point, So that is so profound. And like you said, coming out of it, I mean, with your book, not just patients, but me as a healthcare provider, even thinking about the people in nutrition, the people in housekeeping that you're waiting to come clean the bed, and you wonder why they haven't cleaned the bed because they've called and report on the patient's on the way and the bed's not, it's a tedious little balance,
It is. And even someone like a transporter, which there's a moment in the book where a transporter shows up, and it was actually the editor of my book pointed out to me, she's like, you're treating this person the way you felt like the doctor just treated you.
Mm-hmm.
And it was so, and I try to treat everyone with respect. It was so not on my radar that I was doing the exact same thing.
Yeah, you don't really see it. I tell you, that's one thing I can say now. We use the term essential worker, and I tell them, you set foot in a hospital or a clinic, everybody's essential. If you don't think housekeeping is essential, you let them go home for a day, and you'll figure out that everybody, is essential.
Right.
But, as you're going through the process of the day, it doesn't always register with you, as much as it should, But I was fully vested in your characters, in the doctor, in you, and everything. And I was like, following through with that. So I thought that was just so wonderful. One of the quotes that I have from the book, and I want to kind of segue from the book into the op-ed article that you wrote in February about COVID-19, because this is where we are, so we can't frame a nursing conversation without talking about that. But here's one thing you mentioned in the book. You say, in nursing school, they teach us how to leave. We give our all while we're there, and then we go. So, and I know in writing that, there's a piece of that we all know rings true with nursing, because there's certain things you have to leave,
Right.
But what I wanted to find out your perspective is how has the pandemic, you think, reshaped that a little bit for nurses, particularly those in ICU, because you've worked the unit before?
Well, yeah, it sounds like it's just been terrible for them. And of course, every nurse knows, and I'm sure you know this too, right? The theory is you leave. You don't always succeed in leaving everything at work. Like people say, you come home and you just throw your work memories in the trash can. Well, maybe you can do that if you're an accountant, but, and maybe not, but if someone's died, if someone's, you comforted someone crying because they got bad news. I mean, we've all had these stories. So the ideal is you leave work at work. Doesn't always happen. But I think for so many nurses now, they have not been able to leave work at work. And partly that was pre-vaccination, because they were terrified of infecting their friends, their family members, their kids. One of the nurses, Hunter, I spoke with for that New York Times piece about COVID, told me that the day after he got the first shot, he was driving into work and he had to pull over on the side of the road because he was crying so hard. And he realized it was just all this fear, just months of fear that had been bottled up in him. And this too, that nurses are often the last people in healthcare to talk about therapy or mental health care.
Oh yeah, yeah.
For ourselves. I mean, we'll advocate for it for patients. And that really struck me, that over and over and over, what I heard from nurses I spoke with was, we don't have enough mental health care. We don't, our insurance won't cover it. We don't get help on the job. And also nurses talking about, I come to work crying and I leave work crying. And that said to me that all the horribleness they're seeing, and people, it's very hard for people who don't have a job, where people die at that job, to understand what that's like. And none of us are robots, none of us are machines. All of our well-honed coping strategies can get so overwhelmed. And I think that's what's happened. And so everything they've seen is in their head or under their skin, or whatever metaphor you want
Yeah, you take it home, you do
Right.
some of it with you. And I was thinking as I was reading your article, that even in the pandemic, and we're over a year into it now, that the treatment kind of nurses has changed. In the beginning, everyone was a hero, and you saw
Yeah.
these beautiful pictures of everybody applauding in New York when they got off shift at every shift, and the lights flashing. Our local hospital here organized people to go to the parking lot and flash lights when shift changed and all of that. And there were all kinds of things going on. And so now, post-vaccine, which we're grateful for, people have kind of gone back to their lives a little bit,
Mm.
but now nurses, they're still at that, point that we were last year. I worked epidemiology investigation for DHEC, which is our health department that I used to work for
Wow.
before. And I did that in addition to the other two jobs on the phone from home. So I was spending all last summer on the phone with people asking questions, and they're crying and telling me about their person. And that was a lot for me. And on one call, one or two, I would have to talk to the nurse because the patient couldn't speak.
Wow.
And the nurse, and I would say, thank you for what you're doing. And she'd be like, thank you for what you're doing, because we got to have some relief. So getting this far into it and then seeing now where we are publicly and with nursing, it makes me think about a term that you use that I had not heard, called moral injury.
Mm.
And so can you frame that a little bit for us and for those who will be watching this as to what that really looks like for nursing? I know you mentioned, and before you mentioned the term, I hadn't heard it, but it makes perfect sense.
Yeah, that's a great question. And so the term moral injury was first used to describe veterans. So as a variation on PTSD, I guess you would say PTSD is the symptoms,
Mhm.
right? Of witnessing moral injury. So it's when your actions go against some version of what you know is right. So people would say there's burnout. And I know there's a lot of people who say we shouldn't say burnout because it blames the victim. I don't feel like it does. I feel like it's very useful.
Mhm.
But moral injury is a step more severe version of
Right.
burnout. So on Twitter a few weeks ago, someone was tweeting about having 4 or 5 patients in a COVID ICU. And I said, so that is the definition of moral injury. When you know you have more patients,
Exactly.
you know you cannot adequately care for those patients. You know that if one of those patients dies, it may be because you couldn't take care for them,
Mhm.
care of them the way they needed to be cared for.
Exactly.
So it's
Right.
being put in this situation where you're doing things that will cause harm, either by omission or commission.
Right. Yeah.
But then that's part of your job.
Yeah.
Um,
And that's just, to hear it framed like that just puts such a weight, on it,
yeah,
because, when you're getting this assignment, it's not like what are we going to do if you don't take it? Because, as we all know, we've talked about staffing being an issue before the pandemic,
right,
and so we've always known that there was, a shortage of nurses that were available. And even if you work in a small hospital, there were times when you were working
right,
short,
right.
and you had more patients. But now to have these patients that are in this critical phase, I talked to a colleague of mine, and he mentioned he has a military background, and he said nurses are practicing operational medicine, is what he calls it now, operational medicine, in that you're doing just what you could do. It's like battlefield kind of medicine,
Wow. Okay.
and I was like, wow, and his name is Dr. Tom Cannon. And he mentioned that, he said, that's what it looks like, is that you're just doing what you can, to keep people from being, as sick as but you're working with, and at one point with no PPE or inadequate PPE,
Oh,
or
right.
the rules were changing on PPE, and they were saying you're okay to wear this mask. And then last week we had to wear that.
Right.
I mean, there was so much that was there, and to the general public, they were confused, but we were confused also. And I don't work in, I mean, I work in a university health center, so my risk is much lower than somebody on a COVID unit. But just to see what that looked like, and to see the nurses, and also to know that the burnout rate, like you mentioned in your article, has gone up from 25 to 60%, is just, astronomical. So how to recover from that is going to be something that we're going to have to figure out, I think, as a profession, as nursing themselves. Another thing that I thought about as well, and your article had embedded in it the 15-minute piece that they did on, death from a nurse's view, which I thought was very very eye-opening as well, that I watched. And I thought about the fact that nurses typically are handling patient and family, and they're having the family there, and having the family there is wonderful. I mean, when in labor and delivery, we would love to have family and all that, but there would be a point where it'd be like, okay, we really need the family not to be here so we can do what we need to do. I mean, I really need y'all to not be here for a minute so I can do what I need. But I think about those nurses now in ICU that are having to be the vehicle of grief for these families. Have you been able to talk with them about what that side of death is looking like? We all know that death is a part of what we see in life naturally at some point, but this volume, and then also having to be the vehicle of grief to someone who you've only known for, a small snippet of time, and I'm wondering, have they talked, with you about how that process has been, the dying?
That I will answer your question, but let me say that expression is so beautiful and profound, the vehicle of grief. I really thank you for sharing.
Well, I thank you. Listen, because you're an English professor and you like my words, I'm a word person. I love words. They have so much texture and they have taste and all those things to it. So you have my other dream job, which would be.
Yeah, so we would get along. Yeah.
Yes, we would.
Yeah, I have heard that it's exhausting. And yeah, I did a radio show a couple months ago now talking about this. A nurse who said, we have to be husband, wife, chaplain, brother, sister, best friend, everything. And it's really hard, as in addition to being the nurse, and then sometimes being the one who has to hold up the iPad and talk to the families about what's going on, everything. And I loved this so much. And when we did the Q&A, a doctor called in and she said, Theresa, I just want to really make clear to people listening, when you said the nurse has to be husband, wife, chaplain, brother, sister, people may feel like, well, that's your job. And, that's, what's the big deal with that? And she said, people need to understand this is every minute of every day, every patient, it's just overwhelming, and it's emotionally overwhelming. In terms of managing everything, it's overwhelming. And I really appreciated that. And I think that's, what people have to think about. You imagine you show up at work, it's okay, get on my PPE, and oh, wow, I'm in the ICU and I have, let's say, just 3 COVID patients again. Well, the recommendation is 1 nurse for every 1 patient.
Right.
And you are off to the races the minute you step on that floor, and you do not stop going until you leave. And being a nurse is like that anyway, but this is like that to a degree. My worst days, I can imagine, it's probably every day for them, before the vaccine, the worry, and that you could get COVID, and still with Delta, now the new variant.
Exactly. Yeah, you're right. And then I think about even when we had those worst days in nursing, because every department would have them. And I can recall nights when we had, 3 C-sections, 3 deliveries, we're switching over. I mean, it's just crazy, and you don't get to go to the bathroom or do anything. But what partly got you through that was knowing it's not like this every day. This is a temporary chaos. So I can manage this, because this is not going to come all the time. But to be in a state of perpetual chaos,
Yes, that's well said too. Right. It is like, and I've heard nurses say, this is a war. Right. I feel like I'm at war. And that must be what it's like.
Yeah. So it's just, and I think about, the PTSD and how we often think about dealing with the mental portion of things after the crisis is over. But we really can't afford to do that, don't you? I mean, at this point.
I agree with you. And I'm hearing reports too of nurses walking off the job. And to me, that I cannot imagine what happened for a nurse to walk off the job. Like that just doesn't happen, you know?
Yeah, you try to hold it, it's amazing because I have a daughter that was a certified nursing assistant and she's going to go to nursing school, and she'd taken assignment at a long-term care facility, and you know how they can really burden, the CNAs. And she called me in the middle of the night crying and she's like, "Mommy, I think I'm going to have to leave." And I'm like, "No, absolutely not."
Yeah,
I'm like, "No matter what happens, you have to stay there until 7 in the morning. I don't care what you have to do, but you got to take care of these 15 because we just hold the line.
right.
It's what we do. We hold the line. And so now when we've seen this break, that's happening, it really is something that should not just concern us inside the hospital, but the folks outside the hospital as well. So, and I think that plays back to the moral injury because, to know that you worked that hard and then you leave work and you go into the grocery store and everybody's in there without a mask on, and you think,
Right.
I understand your rights, but do you understand that we are not making headway over here, and it's very difficult,
Yeah. And yeah, this resurgence has been really hard on me, which I don't want that to sound arrogant, because I know I'm not working, I'm not doing the work. But just seeing what's going on in Arkansas and Florida and Texas, and about those nurses and doctors. And, when people break like that, it takes a lot of work to fix a person.
It does. It does. It takes a lot. And I mean, and like they say, some don't have the means to do it. Others don't have the social support and everything to do it. And what we have to remember too is that in addition to caring for what's there, they often have things they're caring for at home.
Right.
So you have your children and your spouse and your parents, and maybe have lost loved ones as well to this pandemic. And in the meantime, you have the nurses that are working in other areas as well that are still doing the normal things, the normal day-to-day medical things, that wish they could be a part of that solution. I mean, we've had nurses come out of retirement, nurses that are senior nursing students that have been given the opportunity to get to work earlier with the nursing board changes because of this emergency situation. So and talking about students, the education side of this has also changed simply because students are not able to get the training a lot of time that they need to. We've had a big upheaval in clinical because, of course, when everything happened, it's like we got to shut the doors, we can't let anybody in, we got to figure out what's going on. So that's been kind of a thing for them. But looking ahead and thinking about students that we're educating, even here at Regis, what are some of the things that you can see that we have to do or change differently? Because overall, what we want to do is be able to have some changes in the environment. Because I like how you mentioned with the floor, when you going back in your conversation, when you mentioned the 2 different floors where you were working. So each floor, has a little different feel, a little different flavor to it, And I used to tell the administrators, I said, when it comes to the environment in the building, the administration is the thermostat, okay? We are just the thermometer. So whatever you see going on with your staff, they're just taking the temperature of what's already here in the building or on the floor in the unit, So as we train nursing students, how do we get that different mindset for them? I mean, the clinical skills we know, the evidence-based practice we know. And in my case, we're teaching providers, but how do we communicate the change that needs to occur even within us, as nurses? And do you feel like, as an added question, like this has changed a little bit the old adage of the kind of nurse eat nurse thing that happens sometimes, has the pandemic had an effect? Maybe solidarity, I don't know, but you tell me from what you've heard.
I think there has been some of that. Yeah, I think the way we need to change, well, one thing is, I think every undergraduate or oh, sorry, I thought I had
That's
turned
okay,
that off.
you're fine.
Every undergraduate or diploma program needs to really teach nurses how the healthcare system really works, that it's this crazy piecemeal. I mean, even coming in older, I had to figure all that stuff out on my own, and sort of, what the payment structures are, what the billing structures are, how nurses are seen as a cost center because our care doesn't get billed for, and all that stuff about how nurses' value is perceived. And then I really wish nursing schools would stress that value. I feel like I've visited a lot of different schools, and it seems like you get the old school, which fortunately isn't so old. Do what we say, don't think for yourself.
Don't ask no questions.
Yeah, right. And then, they have the much more progressive model that says you're a patient advocate. That means you're an advocate for yourself. You add so much value. And I just makes me crazy that we have schools of nursing that aren't teaching nurses to stick up for nursing, stick up for themselves. Like, I mean, I've heard older nurses say, oh, these millennials, they don't want to work, back in the day, blah, blah, blah. I say, you know what? I think it's great that there are new nurses who say, no, you can't just tell me 2 days in advance that I'm working Saturday night.
Right.
Like they expect respect.
Yeah.
And that's, imagine if all 3 million nurses felt like, yeah, let's treat each other with respect.
Right. And we need that,
Yeah,
we definitely do. And then I think, a lot of what is going to have to happen to mend some of the cracks in our profession is going to have to come from within. So unless we build the students so that they're able to speak about the issues and things that we have in a united way, we are going to continue. Because, like with the staffing issue, we've had staffing issues I've been a nurse for 15 years.
Right.
We didn't have enough nurses at the beginning. All of us knew it. Everybody knew it. The administration knew it. We knew it. The insurance company, everybody knew it. But nobody did anything. We talked about it forever. And now here we are. And we were a year ago on the precipice of a pandemic. And we didn't have enough people, and we knew it, but what was there to do at that point? So now where we are, and, we have to find a way from within the profession to create an environment so that we can, be prepared and not just have, more numbers, but also have the kind of camaraderie that we need, to continue to push each other to be better. I'll tell my students, a lot of them, I often ask them when they come in, what did you go into nursing for? And some will say the money. I'll be like, let me tell you.
Yeah.
There are things that they can't pay you enough money to do. But I tell you what you will do. I said, I haven't had a nursing director, and I've been blessed to have great directors. And I had one that when I first started, I was working night shift and I had a story. I'll have to tell you about that later, but it was a whole story getting into nursing. But anyway, I wasn't able to take my boards yet, even though I was out of school because of working. So she said, this is my nursing director. I'm going to work your shift. April Gross was her name. I'm going to work your shift tonight, and I want you to rest, and you go ahead and take your NCLEX tomorrow.
Wow.
And so that's what I did. Okay. I've had other nursing directors who I'm going in. This is my first delivery as a new nurse doing twins in the operating room. And you know what that's like from the bed, right?
Yeah.
So I look up and it's like 7:23 at shift change. And who's coming in the door? Kelly Miller, my nurse director. Oh, I'm going to stay with you until we get the babies out. So see, that I will do anything for. There's no price for that.
Right.
So, but we have to find a way to be able to put that into the new nurses that are coming out, to have that kind of, connection that's there and to foster that, so that, because trust me, that's what's getting probably a lot of these nurses in the units through is each other. And I'm sure, yeah,
that's what I heard. Yeah. And also, sorry to interrupt you.
No, you're fine. Go ahead.
I mean, I also, the more research I've done about what's going on in nursing is people have talked to me about that there is also racism in nursing and towards nursing students. And I feel sort of embarrassed that I haven't seen that. But, in my year in the accelerated program, I guess we did have one Black student who was like me. He had a PhD. He was older. But that was kind of so illuminating to me. Like there's this kind of like hidden racism that the other students don't see, or maybe that you don't see on the floor.
But it's definitely there. It's there.
happening. And
Yeah, it does happen. And you
yeah,
have to look at, even with your nursing faculty, you'll see that, the minorities are not as represented a lot of times in faculty as they should be. So, and I mean, it's difficult for me to tell you where you are when I haven't been where you are.
right.
It's difficult. I mean, I can't tell you what it's like to be where you are because I haven't been there. So it does make a difference to see faces, like mine, and like other minority groups, to look back at you and to see that definitely makes a difference. And unfortunately, it even carries over in patient care environments. I've had patients that refused care because I was African American, in the hospital that I was, and they said, I don't want the Black nurse. But you learn to say, well, okay, we have, someone else. Would you prefer them? And that's fine. And unfortunately, it's even happened with physicians, so depending on what area you're in, you may see it even in those particular, venues. So we try, particularly at Regis, to, encourage diversity and to look at, diverse points of view when it comes to the things that we have to take care of as nursing, because, the enemies that we're going to face in the forms of disease, they don't care. They are indiscriminate. Okay. They are
Right.
indiscriminate, for sure. But it is good, though, that you'll even say that you didn't see it, because it's hard to see when you're not there, and it's kind of different. Like I'll tell my husband sometimes, it's like trying to describe to somebody what it's like to have a baby. I can tell you all the stuff, you can watch the videos, all the things. Until you do it, you have no idea what it actually feels like. So it's very hard to convey, but that doesn't mean we can give up in trying to, do it, because, look at the majority of the providers who deliver care to obstetric patients have not had babies because they're male.
That's right.
But in some way, and sometimes are more trusted than female providers are. You see,
Right.
so how is that the case? So, we have to find a way to get across those boundaries. I don't know that we'll cross them completely ever, but we have to make a bridge that's sturdy enough for us to stand on and meet in the middle, for sure.
Right.
Yeah.
No, that's very well said. Yeah.
We definitely have to do that. So I think that being able to have moments like this to talk to nurses like you, who I just think it was exciting to me all day long. I was like, this is going to be a great opportunity, because to be able to get a broad view, of what's going on in nursing, and we have mutual respect. The hospital I was in was very small hospital, 116 bed hospital in South Carolina,
God.
very small. But it was funny because I can remember having a patient that had some complications, and we had to hang a dopamine drip on this patient. Okay, I'm a labor and delivery nurse. I called downstairs and I'm like, listen, somebody needs to come up here and do this dopamine. I don't hang dopamine. We don't do this. So, the ICU nurse comes up. She's so friendly and lovely. And she's like, you mean to tell me you're an RN and you don't know how to hang dopamine? And she goes and does her thing. Well, of course, 3 weeks later, unfortunately, they get an obstetric patient that has some complications and issues and is in ICU, and they can't find the fetal heart tones. And who do you think they called? They called me, and I went down and said, oh my goodness, you're an RN and you couldn't find that baby. There she is right there. So, there is that regard that we have because we know the specialization, so my nurses that are in ICU now, I pray for them, and, just am so hopeful that there will be a turning of the tide. Meanwhile, I know that as a nurse, I can't do ICU because I don't have the skill set, for ICU.
Right.
But what I can do, and what you're doing, through your writing, is opening the eyes of the public so that perhaps we can reduce some of the moral injury that's coming our way. Hopefully the eyes of administration and our governing bodies like the American Nurses Association and other bodies, to let them know that someone has to speak, for us, in addition to us speaking.
Yeah. Yeah. Well, thanks.
Yes. So I appreciate so much being able to talk with you. And I'm actually going to, if you don't mind, get Andy to give you my email address, because I would really like to continue to follow some of the pieces that you'll be writing, and to also read your other book and to, kind of see where this is going. It's a long journey. It's going to be a marathon. We're in post-COVID nursing. It's changed. It's never going to be what it was. I don't know that we'll ever. Do you think we'll ever be able to go in the hospital without a mask again, Theresa? I don't know that is going to happen. How much of that has changed. And then, conversations that occur like this also can be the birthplace of some innovative ideas. You know, I was thinking today about things. I'm like, what could we do? Could we have an app that the nurses had to do a little survey at the end of shift that would do be connected to an anxiety or depression or stress kind of, you know, algorithm that we could determine, hey, you're at the point where you need to possibly see this therapist counselor. Could we have a counselor that is there at the shift change, that comes in at shift change to do a debriefing of nurses? I mean, with great minds, we can put together some things that are outside of the box, because guess what? The box is all torn to pieces now, you know, where we're at. So, and I think that that's going to come from the minds of amazing nurses like you, Miss Theresa Brown. So we are so very thankful to have had this conversation with you, and I look forward to us being able to connect at another time as well.
Yeah, and who knows, maybe we're even distantly related, since we
we could be.
Uncommon last name.
We definitely could be. Yes, and if not, we definitely are sisters in nursing for sure, because that is something that only nurses can understand. So that we definitely have in common. But please take good care of yourself. And any of the nurses that you should encounter that are working on the front lines, do let them know that the others of us that are not are definitely praying that they will have success, and that we're trying to find ways to help them, because sometimes just knowing that there is help coming, you know, hope is such a powerful thing.
Yeah.
Such a powerful thing. So that hope that something is going to change, and things are changing, not as fast as we'd like them to, but that hope is definitely something that can hopefully anchor them while we weather this crazy storm of COVID. All right.
Thank you, and take care.
Thank you. You do the same, and have a great day. Bye-bye.